afternoon, everybody. I bring greetings to Bangladesh from India. We are going to discuss what are challenges and solutions in management of GDM in South Asia. It is about me, and I owe a big gratitude to all SAFOG leaders for being together since a long time as my tenure for FOXI representative to SAFOG and now as a SAFOG co-chair and CD committee. So we say that South Asia loves festivities and celebrations. Are we prone to diabetic as a race, or it is a result of sharp change in lifestyle and environment which has created epigenetic change? It is a question before us, but it is a fact that GDM is around the corner and can be anywhere in obstetrical population. GDM is an important public health issue in India as well as South Asia, because it represents large subset of population at high risk who can have adverse obstetrical outcome and even mortality if it is not appropriately managed. Besides this, the perinatal implication of GDM marks beginning of a vicious cycle, because diabetic mother gets diabetes, leaving a legacy which can affect to mother as well as her offspring. Her mother can have the frank diabetes mellitus later on, and her offspring can also have metabolic disorder. So at the moment when South Asia is facing tsunami of non-communicable disease, our intervention from obstetrician, a good screening, a good care in the management of GDM can go a long way in preventing this tsunami of non-communicable disease in our population. So what is GDM? It is a carbohydrate intolerance of variable severity, which is either developed or it has been discovered for the first time during pregnancy, irrespective of gestational age at which it is diagnosed. It is definition still implies whether we use any pharmacotherapy or not, and it also includes some women who have previously unrecognized overt diabetes. Why we use GDM? Because the term gestational has been encouraged to communicate the need for enhanced surveillance and to stimulate women to seek further testing postpartum. So GDM, we have to be very clear in defining. As I say that it is the intersection of two important areas of health, that is maternal and child health and non-communicable disease. And both are a crucial health issue in South Asia. And the potential for successful management will determine what is the pregnancy outcome. And it also have the opportunity to prevent type 2 diabetes mellitus in later life. And here we join hand among all countries of South Asia that how we can do the best for our women. It is the most common metabolic disorder during pregnancy. In Asia, the average can be from 5 to 16%. And out of these, 7 to 8% of GDM patients are insulin dependent. And International Diabetes Federation estimates that around 2015, around 16.2% of women with live birth had some form of hyperglycemia in pregnancy. So magnitude is a big, and with a large population, what South Asian country have, we contribute to a good number of absolute patients who are having GDM. So it is again emphasized that Asia, who has been known as a father of DIPSI-SAT and father of creating awareness about GDM in India. And he also concludes that right from rural to urban, the incidence of GDM range from 9.9 to 17.8%. In Sri Lanka and Nepal, the prevalence is a little low, that is around 5.5 to 7.1. So it can be right from 5% to 16% in incidence of GDM in our obstetrical population. Now, screening for the GDM is the question is very, very simple. And we come to first, we ask the question, it should be universal versus selected. At what trimester we should do screening first and late second, or we have to confirm with third trimester also. And how do we screen for the GDM in a large number of normal obstetrical population? So the many professional bodies have got a different recommendation, and in India we are in line that we follow mostly the DIPSI, because as we say in the Western world, the incidence of GDM is low because of many factors, because of ethnical susceptibility, and it is our problem which we have to face the challenge. I want to convey very, very important message that urine glucose testing, fasting plasma glucose or random plasma glucose or the postprandial plasma glucose have the low sensitivity as a screening test for GDM. So it should not be used as a screening test for GDM. Because if we do testing without administering a glucose load, which will help to come the impaired, a minimal degree of carbohydrate intolerance to become overt. And a HAPO landmark multinational study demonstrated that we have, when the mother who have the higher glucose level, they have the more adverse obstacle outcome. And the previously considered normal values are associated with the adverse perinatal outcomes. So we have lowered the bar of glucose level in pregnancy, and that is less than 100 milligram per deciliter as a fasting blood sugar. Our Indian guidelines and the FOXI recommend the screening for GDM at first visit, and then it has to be repeated again in the second trimester. And in Sri Lanka, there is a universal screening of GDM at 24 to 28 week pregnancy, beside the screen for pre-gestational diabetes at the booking visit. So yes, we have lowered the bar for the diagnosis of GDM, and that has also contributed to increase in number who has been diagnosed as GDM, but the lower glucose level are related to a good obstacle outcome, and this is the way forward. So the DIPSI recommendation, that is Diabetes in Pregnancy Society of India, that the universal screening is recommended, and it should be first at the 16 to 18 week, then 24 to 28 week, and a woman, irrespective of her last meal, is given 75 gram anhydrous oral glucose load, and after 2 hours a venous sample is taken and the plasma glucose level is estimated. And if these value is more than 200, the patient is considered frank diabetic, and if it is more than 120, then it is says impaired glucose tolerance, and if it is more than 140, then we label that this patient is having gestational diabetes mellitus. So second question to our clinician is that, yes, we do universal screening, though it is still important to take the history indicated risk women and do the closer surveillance for the GDM. Yes, answer is yes. Women who are at high risk of overt diabetes, like the patient who are obese, history of GDM in previous pregnancy, previous large babies, bad obstacle history, unexplained stillbirth, and the history of congenital malformed babies. Be very, very careful, and these women should have this level at first prenatal. It has to be repeated in every trimester, because these women are more likely to have GDM, and and we have to be very careful that the patient in between has not developed the gestational diabetes mellitus. Why it is important to identify women with overt diabetes or the pre-gestation to all clinicians? Because women, if the first antenatal visit, that is around 6 to 10 week or 6 to 11 week, patient is having higher blood sugar level, then we should consider that the patient was having pre-gestational diabetes mellitus, and these women are at the increased risk of congenital malformation in offspring. They are more risk for diabetic complication like nephropathy and retinopathy. They need prompt treatment and normalization of blood glucose level, and they need to ensure proper treatment of diabetes after pregnancy. So the first trimester screen positive to be taken as a pre-gestational diabetes, and these mother has to be followed, and these fetus also has to be followed very, very closely. And it is the diagnosis of overt diabetes, but it is a fasting plasma glucose level less than 126, and the random around 200 milligram per deciliter, and HB1AC 6.5%. So pre-gestational diabetes or the impaired glucose tolerance in the first trimester to be taken with a quite bit of caution. Yes, professional bodies and the experience differs in all over the world, and still we don't know that actually what level of blood sugar need to have the full treatment. Yet the treatment of the even the minimal degree of gestational diabetes mellitus or minimum level of the impaired glucose tolerance really result into the improved obstetrical outcome. So these are the issues. These are the good papers from India which says that we should universally screen. The DIPSI test, that is a 75-gram anhydrous glucose challenge test, irrespective of last meal, is a very, very good screening test. It picks up quite a majority of the patient with GDM. And this is the simple way forward, because our women, when they come into the antenatal clinic, they are not supposed to, they come from a long way and they are not supposed to be fasting, or they wait full over the day for the full glucose tolerance test. So this is very important. Landmark study experience and evidence from a large population and who is having a large from the large continent, the area of the world, and this is the way forward. So this is important that we have to screen everybody, screen rightly, and screen in a simpler way so that we can reach to the majority of our population. Now coming to management challenges. So this flow chart seems very complicated and we will take the issue one by one. So the very, very common situation, second gravida, last childbirth 3 years ago, weighing 670 kg. And when the DIPSI test was done, it is the blood glucose level is 156 milligram per deciliter. A very common clinical situation which we face every day. Then the question is what next? When we do a screen, what next? What you do, you advise diet and lifestyle, you advise immediately drug, you refer to some physician, or you ask the patient to do the self-monitoring and buy glucometer. So we will like to do simple clinical message, what is used and what is recommended and what gives the optimum management for the GDM. What are our goal of treatment? When we have diagnosed that this patient is having GDM, we want to have a pregnancy outcome at par with the non-diabetic woman. And for this, we need to have a good blood sugar level that is below 120 milligram per deciliter to our postprandial. And the cornerstone of the management is diet and lifestyle. With or without drug, diet and lifestyle is the way all over the life, the woman who is being diagnosed as the gestational diabetes mellitus. Now, medical nutrition therapy, it is a simple thing or it is a complex thing. So we have a lot of busy obstetrical OPD and a low risk patient and a high risk patient, and how we can give that time to counsel that what is medical nutritional therapy for the GDM. So it is better said than done, and we will take a few quick things which we can explain to a woman very, very quickly, woman along with family. This is very important because food is not a woman's business only. It is a family thing. So you have to say 3 or 4 important points. Break your 3 large meal into the 6 meal, that is 3 meal and 3 snack. If the woman is a heavyweight or obese, she has the different lower calorie requirement. If the woman is having low BMI, then she has a little larger calorie requirement. But out of these calories, the 50 to 60% from complex carbohydrate, 20% from protein, and 25 to 30% from fat, out of which less than 10% should be from the saturated fats. So this is very important. The food which is having low glycemic index. Low glycemic index, what does it mean? That it raises the blood sugar level slowly and it takes a long time to digestion, so that we don't have the fluctuation of the blood sugar level too high and then suddenly too low, and the patient is having again hunger pangs. So this is very important that you have to tell that you take the full grain, full nut, full fruit. Don't take the cold drink, don't take the sweet. So this is very, very important. Advise a diet modification what patient normally eats. Don't say the thing which the patient has never listened, that what vegetables. So make the issue of the cultural thing and the economical thing also. Like you always ask to take the simple seasonal food which is available and which is cheap. It is also important that don't advise severe caloric restriction because it is a pregnancy state where the fetal organogenesis is going on. And if there is a severe caloric restriction, that can cause ketonemia and IUGR, and as well as it can affect the intellectual development of fetus. The written diet chart, because sometimes you don't have that much time, it can be busy day. So it is always important that you prepare a written diet chart with reasonable choice of food, which help in learning as well as following, because chart is with the patient, it is with the family, and it can be shown, and the diet can be altered in the management of GDM, because the diet plays the most important role in the management of the GDM. Exercise is important somehow. With the mobile technology, with the change in the lifestyle, the South Asia people has always been physically hardworking, but it is not now so. But we have to emphasize that the regular exercise help in achieving target blood sugar level, as it improve insulin resistance by increasing the glucose uptake by muscle. And at least 30-minute exercise, it may be the simple walking, it may be the pleasurable exercise, that should be advocated in the management of the GDM. Now, the third question is arise to our every clinician, every obstetrician, that when we should consider pharmacotherapy. So patient has been prescribed 15 days the maternal nutrition therapy. She was following well, but it is still 150 or 160 sometimes. So I will like to give very, very clear message that when to start pharmacotherapy and how to choose what pharmacotherapy is required for the patient and what is the best for the patient. So don't take pharmacotherapy for a one single reading of the hyper blood sugar level. If ask the patient to maintain the blood sugar level for the last 7 to 10 days. If the 30% of blood glucose values in a week are above target glucose threshold, then it is time to start any drug. Maybe it is insulin, maybe it is oral hypoglycemic, because that reduces the reduction of preterm birth, NICU admission, and the fetal macrosemia. So very clear message I am giving to all of the audience. When over 30% of blood glucose level in the week are higher, then you consider that it is time to add pharmacotherapy along with the maternal nutrition therapy and the exercise. So it is 15 days maternal nutrition, medical nutrition therapy. And if the blood sugar level postprandial is less than 120, continue with the maternal nutrition therapy, but you have to have a 2-hour PPG blood sugar level watch. Up to 20 weeks, it should be once in 2 weeks, and after 28 weeks, it should be once a week, because anytime patient can have the lose the control and can have the unstable blood sugar level. But if after 15 days of good following of medical nutrition therapy, the blood sugar level, 30% of the levels are more than 120, then you have to start pharmacotherapy. Insulin is still drug of choice, the first choice for the management of GDM. And these patients, when they are on drug, then the fasting blood sugar level and the 2-hour PP blood sugar level should be measured every third day or more frequently till insulin dose are adjusted to maintain normal plasma glucose level. And once weekly, you have to monitor 2-hour PPG. So this is the minimal surveillance which we need for it. So now coming to oral anti-diabetic, and there has been a lot of confusion among clinicians, and sometimes some people are writing right and left metformin like iron and calcium. So where is the need for oral anti-diabetic? What the patient wants from us. They want good blood sugar control. They want good obstetrical outcome. They want short-term and long-term safety. They don't want any adverse effect. And they are always concerned for long-term consequence in offspring. What is a healthcare system? What are our issues that the cost and convenience has to be taken care, because we are serving a large number of the complex and the heterogeneous population. So I will just go in brief that the 2 drugs are available as oral hypoglycemic agent, metformin, which is a second generation biguanide. It reduces gluconeogenesis in liver and limit glucose absorption in gut. It does not produce insulin, so it does not cause the neonatal and maternal hypoglycemia. And I want to emphasize that the mechanism of here is by renal tubular secretion with minimum protein binding, so that the doses need a little bit adjustment. Now, how the metformin is effective? So we have got a big number of trials, and I will share few. My MIG trial, which is very important, which has been compared metformin with insulin. So we will emphasize two things. First of all, it is quite effective in controlling blood sugar level, and a neonatal outcome like preterm birth, RDS, and hypoglycemia is quite good and comparable with insulin. Important thing is that patient on metformin, around 46.3% women needed supplement insulin to maintain euglycemia. So this is very important, because when you prescribe metformin, it is very important that you monitor blood sugar level, as we said, and we must be ensured that the blood sugar level are being controlled in the normal range. Another important issue is the long-term exposure, and what TOFU trial has shown that the patient who has been given metformin and not insulin, they have more visceral fat in the subcutaneous tissue. And we don't know what is the reason, but this is the important observation. So the all randomized trial and the Cochrane review says that the metformin is good in reducing gestational weight gain, birth weight reduction, macrosemia less, neonatal hypoglycemia less, the reduced risk of PIH as well, but we are not very sure about the long-term effect. Because metformin crosses the placenta, the fetal level is around 700 times more than the mother. So we have to be very, very careful, and that's why even the American Diabetic Association and others say that the oral anti-hypoglycemic agents are not the first choice, though they may be safe. I want to emphasize that the transfer in human milk is minimal, so the drug can be given safely in lactation. PCOS women are different, because the PCOS women, we give metformin in the first trimester even, because they improve insulin resistance and the obstetrical outcome. But the pure GDM have got the certain issue, and it is considered as a second choice. What is the dosage of metformin? Start 500 milligram orally once in the dinner, and then the maximum dose is 2000 milligram TDS or QID. It is again important that the side effects are nausea, anorexia, diarrhea, which is not acceptable. The pregnant woman does not take it very easily, and around 2% of women discontinue metformin because of the GIT side effect. So metformin versus insulin, we emphasize a quite good blood sugar level and the neonatal complication, but we are really worried about failure to control blood sugar level around 40% and the long-term side effects on the offspring. A word of caution again with the metformin, that the women with hypertension, preeclampsia, and the women who are at risk of IUGR, in these situations, metformin is not the drug of choice, because metformin suppresses mitochondrial respiration, which may again adversely affect function, growth, and differentiation of fetal or placental tissue. So this is again an important point of caution. Glyburide is another drug which has been studied in GDM. It acts by producing insulin by acting on the insulin receptor, and it does not cross placenta in significant amount despite its low molecular weight. And they are very issue, but insulin dosage is 2.5 to 5 milligram once daily, and the drug, if take 30 to 60 minutes before meal, it is a good efficacious drug. But as it acts by producing insulin, the maternal hypoglycemia as well as the neonatal hypoglycemia is a very common side effect. However, glyburide is not considered a very good drug for the management of GDM. This I want to emphasize to all audience, because it is associated with higher incidence of macrosomia, neonatal hypoglycemia, preterm birth, and again in around 20% of women, there is no real control, a good control of blood sugar level. So glyburide is not that it has got associated with less control of blood sugar level and the more neonatal complication like large for gestational age, RDS, and NICU admission. So as a monotherapy, glyburide is inferior to both insulin and metformin. And metformin with or without insulin can be considered in select situation. and we still don't have the safety data for the long-term effect of metformin, and that should be communicated to our patient. So finally, a word that what is the place and role of oral hypoglycemic agent in GDM? DIPSI still doesn't recommend oral hypoglycemic agent for the first line management, and the final takeaway we can say that the oral hypoglycemic agent, that is metformin. I will say glyburide is not drug of choice. Metformin can be considered as alternative to insulin when the patient need pharmacotherapy. Like 30% of blood sugar level are higher on maternal nutrition therapy, but they decline to take insulin or they are unable to comply with the insulin therapy. Various guidelines are inconsistent, and the second choice is when the patient is having normal fasting blood glucose level and the modest postprandial hyperglycemia. So patient is having normal fasting but a little higher rise of postprandial hyperglycemia, then metformin can be considered in those select situations. Besides this, that the couple or the family is not at all able to maintain the insulin regime. So this is very clear message, and we should be very, very clear that which patient need can be selected for the oral hypoglycemic agent. Inositol has come in a big way because the medicine is searching for the nutritional supplement, not the drug for the many disease. And the many research says that if we give inositol supplementation, it prevents the development of GDM, or it prevents the severity of it reduces the severity of GDM. So still we don't have the final evidence, but it is a good thing because these are inositol, they are nutritional products and they don't have any side effect. So coming to insulin. So after understanding that how the two drugs act, metformin is better drug, but it is always a second line drug, and the patient has to be selected. A very, very few number of selected patients can be considered for the oral hypoglycemic agent. Now, when to start insulin? Again, whenever the maternal nutrition therapy is not able to maintain the good blood sugar level, and we have to switch. Insulin is still the gold standard therapy. Now, we can say that we can refer to the physician or we can refer to endocrinologist, but majority of our patients as well as us are not that always availability of this, that you ask the patient to say, ask physician to go physician to today and they will go after 7 days. So we must have the basic knowledge what is insulin and how the dosage is adjusted. If the patient is having pre-existing gestational diabetes mellitus, it is 0.7, 0.8, 0.91 from the first trimester to the term, and these patients need 3 injections or maybe 4 or 5 injections. But if the patient is only GDM, you have detected in second trimester, then usually the once daily insulin may be suffice, or sometime twice a day if the fasting blood sugar level is high, and the pre-mixed insulin is most convenient. So we must have as an obstetrician the basic knowledge, that is 30-70 insulin, which is given just before the breakfast and before dinner. And the single injection, sometimes it is only needed with the GDM who are having the high faster blood sugar level. Now, the next question is, how do you monitor mother and fetus in GDM? So this is important, how to monitor blood sugar level. So I will like to give a very, very clear message that the home glucose monitoring is cost effective, economical. It is educating tool, and it gives a good profile and a good calendar that what is happening to the patient, because nobody can go to lab and then put and at that day they eat less meal, and the result can be very, very confusing. So it is important that we should advocate we should give them confidence for the self-monitoring. And I again wish to emphasize that HbA1c should not be used routinely for excessive glycemic control, because of rapid RBC turnover, it can be deceptive. So train them, diabetic nurse and our nurses can train how to do the blood sugar examination. And to my experience, even the rural and uneducated people fantastically monitor blood sugar level, and we get a very good charting of the blood sugar level in their diary. So we have to believe in people. It is not only the education or the money, it is the simple wisdom which the nature has given to everybody. So educate patient, believe in them, ask the patient, ask the nurses to train them and how to read the result and how to write it. So oral insulin is also in the research. I will just touch upon oral insulin because when the whole world is having metabolic disorder, it can be oral, buccal or inhaler, and it is in the way of the research, and maybe we can have oral insulin later on. Now coming to the maternal surveillance, these women need to have close monitoring for or other disorders, irrespective of blood sugar level, because if they has been diagnosed as a GDM, you have to have a close surveillance for preeclampsia, hypertensive disorder, thyroid disorder, and the genitourinary infection. This is very, very important because any infection can cause very rapidly to the diabetic ketoacidosis and the uncontrolled sugar level again. So you have to be, and you have to treat warn the patient and counsel what are the signs of hypoglycemia as well as the diabetic ketoacidosis. I will just touch upon very, very briefly diabetic ketoacidosis because it is a life-threatening emergency and we want to save every mother everywhere. And we don't want to lose the patient because patient was not diagnosed and treated for diabetic ketoacidosis. So what are the factors which precipitate diabetic ketoacidosis? It is infection, hyperemesis, non-compliance, use of steroid, and the beta-sympathomimetic drug. So be very, very careful when you prescribe any beta-sympathomimetic drug or steroid for the lung primary. The patient should be hospitalized and it needs prompt diagnosis and prompt treatment. So how to recognize the patient of diabetic ketoacidosis? She is hypotensive, hyperglycemia, sugar level, dehydration, tachycardia. She is having the thirsty, hyperventilation, nausea, vomiting, and she can have the fruity odor, and we can have a good lab result if after the clinical examination. So what are the basic issues? Yes, we can always, it is a multidisciplinary approach, but we must know two things. That we have to overload the patient with the normal saline. That is in the first 2 hours, it is 1000 ml per hour. And after that 0.45% NaCl. And why this infusion is necessary? Because only then the insulin can reach to the tissues. Otherwise, if we don't give the good fluid, that is normal saline, then the insulin is not going to reach the woman's tissue. So the 0.91% are normal saline and initially fasted, then controlled, and give insulin 10 to 15 unit insulin and then give the insulin infusion, and by the time your endocrinologist and physician is on the scene. So basic thing that we have to be alert that at a even 180, at a lower blood sugar level, the GDM pregnant patient can develop diabetic ketoacidosis. How to diagnose clinically, suspect clinically, and confirm it with the blood sugar level. And the second is the first line treatment is normal saline, fast fluid, and the insulin infusion. So this is very, very important message which I want to give to audience. How to follow fetus? Do you bombard every week or every 10 days ultrasound? So I will say, be very, very clear in your roadmap. Yes, every woman needs 11 to 13 week NT scan and the biochemical screen for aneuploidy and anomaly scan at 18 to 20 weeks, which is more important in women with the diabetes mellitus, and fetal echo if around 20 weeks. The growth scan should be done at 28 to 30 weeks and then 34 to 36 weeks. So this is the simple plan which we should give to the patient, that how frequently you should have the ultrasound. But if the patient is having hypertension, preeclampsia, she is on insulin, she is having unstable blood sugar level, she has a bad obstetrical outcome, that is history of stillbirth and the pre-gestational diabetes. These fetus need very, very close surveillance, and these women should be monitored with twice weekly NST test starting at 32-week pregnancy with biophysical profile as a backup test. And when the patient diabetic, combination of diabetes and the IUGR, when there are uncontrolled blood sugar level, there is a polyhydramnios and fetal macrosomia. But if there is associated vasculopathy, then the fetus is IUGR, and this combination can be very, very dangerous. And in those situations, again, twice weekly NST and the Doppler studies are very, very useful. However, no single test of fetal surveillance is adequate in diabetes, and we have to take the full clinical picture into consideration while we make assessment of fetal well-being. Now coming to the last thing, maternal nutrition therapy, pharmacotherapy, maternal and fetal surveillance. Now there is time to delivery, and always there is a fear among patient as well as obstetrician that if we delay pregnancy, then we can have suddenly stillbirth or a complication. And if we do the preterm induction or preterm cesarean, then again the diabetic babies behave like more premature baby and we get a lot of neonatal complications. So where is the balance? So we have to be again very clear and the confident picture that what are the issues. The fear is one fear is for the unexplained stillbirth, and the second fear is for the complication in labor like shoulder dystocia or traumatic delivery, and how to take the decision. So the guiding line is the decision is the control of blood sugar level, associated maternal complication, what is the fetal weight, and the prediction of birth weight. So these should be the guideline that we decide timing and mode of delivery. And they are very, very important consideration. I will again say, yes, the obstetrician fear and the woman's fear is also quite right, because we do get sudden stillbirth in the GDM patient. So it is important that the women with elevated fasting glucose level have elevated rate of unexplained stillbirth. So if the patient is having constantly elevated fasting blood glucose level, you have to monitor the insulin therapy and change the schedule. So I now give the clear picture that patients who are fully controlled on medical nutrition therapy, they should be followed till 40 weeks, and then induction should be considered if they don't go into spontaneous labor by on their own. Women on insulin or oral hypoglycemic agent should be considered for induction of labor at 38 to 39 weeks because it reduces risk of macrosomia, shoulder dystocia without increase in cesarean section rate. However, if there is a maternal or fetal complication like hypertension, IUGR, in those cases, we have to set the priority around 36 to 37 weeks. If there is a preterm labor induction, give steroid, but always admit the patient and intensify blood glucose monitoring and increase insulin dosage if the patient is on insulin. Always assess clinically as well as ultrasound fetal weight gain and the cutoff for fetal. If the South Asia, if the baby is more than 4 kg, then it is better that we go for the elective cesarean section. Intrapartum, if the patient is in labor or it planned for the elective cesarean section, intrapartum glycemic control is important because if the blood sugar level are high, then it can cause also the neonatal complication. What level we want? Around 100 milligram per deciliter. And we can control it by rotating glucose containing and glucose free IV solution, and blood sugar level should be checked every 1 to 2 hours and with the insulin supplementation. However, patients who are controlled only on diet do not require insulin, but every GDM patient needs close fetal heart monitoring, preferably with the CTG at intermittent labor. Good labor analgesia is very, very important because when there is more pain, it can also aggravate the blood sugar level also. And that long trial, difficult trial of labor has no role in management of diabetic patients. Again, I emphasize that few drugs like sympathomimetic drug and the steroid can precipitate diabetic ketoacidosis. So be very, very cautious, and the GDM patient can have the ketoacidosis at a low level. So these are the intrapartum complications which a GDM patient can have, that is shoulder dystocia, birth injuries, unexplained stillbirth, increased instrumental delivery, of course, cesarean section, then PPH, and the infective morbidity. So we have to have a good fetal monitoring when the patient is in labor, because the diabetic fetus have got the more visceral fat at the shoulder level, and that's why they have the more chance of shoulder dystocia. So in these patients, ask your paramedical to do the prophylactic McRoberts maneuver, perform active management of third stage of labor, and close watch for PPH, and ensure neonatologist availability. That is very, very important. And in cesarean section 2, in macrosomic babies, readiness for difficult delivery of the baby. Goodbye messages are in postpartum care, there is a fall in insulin requirement. So be careful that you have to reduce insulin dose, or you may switch to non-insulin as well. And early breastfeeding is the way, and always check for the blood sugar level at 6 weeks postpartum, give them a good contraceptive device, and lifetime counseling for diet, exercise, and the weight reduction. So, what are the challenges in South Asia for GDM? Among healthcare workers as well as among people, we have less knowledge about GDM screening and the diagnostic protocol and the management protocol. We have to focus on the prevention and the adherence to the standardized protocol, and we have to train our sisters, our nursing staff, and our Anganwadi, the mid-level staff about the importance of screening and how do they screen and how do they advise for the medical nutritional therapy. So this is very important challenge. We have to have the solution that we provide evidence-based care in resource-constrained setting. So the world has changed. A lot of high sugar intake is there, and we have to return to our convention, right from individual to family to health system to community to the global. To bridge the gaps in knowledge and practice by creating evidence, by sharing experience, and the population and our experience should create evidence, and our experience matter. Thank you very much for patient listening, and thank you very much for staying together. And we miss meeting physically at the Bangladesh, but hopefully we will be soon together in physical as well as the virtual platform. Thank you very much.